Good morning, everyone. Thank you for joining us for our annual HBCH Wellbeing Program. We've got a lot of folks getting online right now, so we'll begin here shortly. Sam, if you can go to the next slide, please. All right, so the annual well-being program, well, where are we going, Sam? That's fine, you can keep it there. This is going to be a great discussion. Our annual well-being program is probably our most well attended. Of course, this year is a bit different given circumstances in terms of number, but popularity, we still have an awful lot of folks interested in this topic. So I've been in this business for about 35 plus years, the first 20 or so years from the employer side, with a variety of responsibilities for health management in larger energy companies. The last 15 years have been evenly divided between my time as a consultant and researcher in health and productivity management. And then the last, tough to believe, it's 6 years now as executive director of the Houston Business Coalition on Health. And so as I was reflecting on this meeting, I was thinking about how things have changed in the wellness, well-being space. Back in the 80s, when I was first involved in health and productivity management, wellness was, I won't say new, but everybody did not have a wellness program. When times got tough, the wellness programs back then were the first things to be cut. I don't think we'd see that today. That has expanded to a more holistic approach of the individual to encompass the concept of well-being, physical, intellectual, emotional, spiritual components, and that has been addressed by a lot of employers over the last decade. Interestingly, several years ago, when I became executive director and was traveling the country, the CEO for the National Alliance, Mike Thompson, was talking about mental health. And I remember coming back to my board and saying, where does this stand with you? And the answer was, well, there's a lot more things coming across our desk, but it's really not on our radar screen. Fast forward about 5 years with where we're at with mental health. And then, of course, more in the last few years now, we've expanded that discussion, and rightfully so. Most employers hadn't even been aware of the term, let alone considered addressing social determinants of health as a core strategy within their organization. COVID has certainly brought that to light, and why that is so important. And then beyond social determinants of health is the equity portion of the discussion. So our topic today is focused on the employer and their role, their need for awareness, both within their corporate walls and within the community, to talk about these issues, and not only to talk about them, but to act on them. So I'm extremely excited with what we have for you here next. Sam, next slide, please. I know there we go. So this is our agenda for today, and you can see we're going to lead off with Elena Marks, who is the CEO of the Episcopal Health Foundation, and whom I've had the pleasure of getting to know a bit over the last year and a half, 2 years. Following Elena, will be Jessica Brooks. I've known Jessica a little bit longer than that. She is the CEO of one of our peer organizations in the National Alliance. She's the CEO of the Pittsburg Business Group on Health, and she has, quite frankly, been a national leader on this topic from the SDOH as it pertains to equity and looking at it from the employer lens. So we're pleased to have Elena and Jessica, and then we'll have a panel discussion, and we can take a few Q&As from the audience, and you can put those into the chat box, and Sam Medina and Corey Owens, our operations manager and admin, will do a great job. So if something doesn't go right, you know who to reach out to as well. Invariably, something will go wrong. It seems to be the nature with these webinars these days. So looking forward to that discussion. And then we're going to talk about every workforce deals with, they have an obesity prevention, obesity initiative. It's somehow embedded into their well-being approach. But maybe we're going to look at this a little bit different from the employer end. How does obesity and social determinants of health within the workforce play into this? So we're looking forward to that discussion with Courtney Walker, who Dr. Walker is with Novo Nordisk, and then last we are going to talk and have a little bit of an open forum to hear your concerns about well-being going forward, especially in the first part of 2021. You'll probably find some common threads there. So again, very excited for this. This is a great panel. So Sam, next slide. So we're going to start with, again, Elena Marks, who is the CEO of the Episcopal Health Foundation. And Elena, if you just want to start your video here, and I'll get off here as soon as you get on. And again, I remember meeting Elena a few years ago in her office, and this was one of the first things that came up. And I know Elena is so committed to this in our community, and her approach to providing health, not healthcare, that resonated with me. And I see this discussion occurring so much. I was on a national webinar with the National Alliance yesterday. This is a national topic, and we are fortunate to have Elena as a leading proponent and an expert in being discussed that. So I will part, and you are on your way. Thank you, Elena.
Thanks very much. Next slide, please. Okay, next slide, please. So thanks so much, Chris, for allowing me this opportunity. I want to tell you a little bit about Episcopal Health Foundation, and then I want to tell you why I'm so excited to be here speaking to this audience. So for those of you who don't know us, we are a relatively new organization. We are the byproduct of the sale of the St. Luke's Episcopal Health System. That transfer took place in 2013. The proceeds were about $1.3 billion. And the Episcopal Diocese of Texas, the church, actually owned the hospital system. And so upon the transfer, they created a new entity that they named the Episcopal Health Foundation, and they put the $1.3 billion into that. And I got hired to run it, which is like the best job in the world. Because we are fully funded, and our mission is to improve the health and well-being of the people who live in the 57 counties that make up the diocese. So basically, we have Southeast Texas. We go over as far west as Austin, We go up to Waco and then up into Northeast Texas to Tyler. The 57 county lines don't mean anything to anyone but the church, but basically we've got 11 plus million people. The large urban areas like Houston to small towns like College Station or Lufkin to very rural areas. And our approach is really to work upstream and look at root causes and system level changes. And it's a gift that we have and an opportunity to do that because we are untethered. We're not part of the healthcare delivery system. We're not aligned with hospitals or health plans or employers or anyone else. Our mission really is about the people, and particularly the low income population. We operate under a strategic plan that's built around 4 outcomes. The first one is health system reform, and this talk today really fits into that. And it's built on the belief that the $3.6 trillion that we spend in this country, public and private dollars, on health ought to actually be producing health outcomes. And yet we have a system that prioritizes health care, which is great and important, we all need it, but it does that at the expense of social determinants, if you will, and other health promoting possibilities. So we're not out of the healthcare system. We do a lot of work in the primary care system, particularly with community-based clinics, the federally qualified health centers, because they really have one foot in the health care community and the other foot in the actual community. And so they are the bridge for us between the health care delivery system and the actual people who need services and need better health. We also have an outcome around activating communities, and through that we work with a lot of grassroots community organizations. The theory being, if you want to change the health system, you have to have the community on the other side saying, this is the system we want. And so we want to help them learn how to advocate for their own needs. And lastly, we have a goal around early childhood brain development. We're focused on the 0 to 3 range, and we do some of that work through the healthcare system, through pediatricians, and we do some of that work through community-based organizations. And it's based on the science that shows that the physiological changes that happen in a baby's life, really from prenatally to about age 3, are amazing. And the opportunity that you have to make lifelong health affecting changes at that window is unreplicated later in life. So mostly we're working with low-income people, some employed, mostly employed, some unemployed, some documented, some undocumented, lots of communities of color. And I'm really excited to be talking to an employer group today because you all have a lot of say in where our health dollars go. We know that employers are responsible for about half of the health insurance in this country. And so when you make changes in the way you focus on what you're buying for your employees, you can affect the entire system. And so I'm really delighted to have an opportunity to speak with you and hopefully after this to partner with you on items that could be good for the populations I serve and for your employees as well. So next slide, please. So I'm going to talk to you today about social determinants of health, not healthcare. And I'm going to start with a basic definition and short video. For those of you who know this stuff inside and out, I apologize. You could do this talk in your sleep. But for some of you, this may be a new topic. And so I'm going to go back to basics. And next slide, please. Next slide. Oh, there we go. Okay, so this is a back one. Basic definition of social determinants of health. This comes out of the CDC and Healthy People, which is the nation's public health plan for a decade at a time. But it really has to do with the environment, the social environment, the physical environment, the economic environment that people live in, and how that actually affects their quality of life and their quantity of life. I'm going to ask Sam to please click on this short video that does a great job of explaining really simply the social determinants. Sam, we can skip it. It was short and cute and sweet, but we can skip it if it's, I don't want to waste a lot of time on it. Let's go on to the next slide.
Okay.
Thanks. So this slide summarizes what the video was talking about, and it's based on decades of research that shows what factors or drivers determine health outcomes. And that's measured in terms of how long you live and the quality of your life while you're living. There's another version of this by the Institutes of Medicine, and it adds in genetics. And if you add in genetics, then medical care gets reduced to 10%, and genetics picks up that 10%. And so when you look at this chart, and it's not precise, it's not exactly 40% is attributable to this and 30% is attributable to that, but it's relatively accurate. And if you think about what makes a person or a family or community healthy, you understand that the social and economic factors are huge. Do you have family supports? Are you employed? Do you have education? All of those things really affect your chances at a healthy life. When we go to health behaviors, we know that smoking is still the largest cause of preventable death. We know the importance of diet and exercise. We know what substance use does. Then you go down to the physical environment. You understand if you live in poor housing, your housing can be making you sick. If you live in an area with environmental contamination, that can be making you sick. And the medical care, the access to it and the quality of it actually only accounts for about 20% of what makes a person healthy. So you think if you know what the drivers of good health are, then we'd align our resources accordingly. So let's go to the next slide and look at how our resources are aligned. So if you compare the drivers of health, the column on the left is the same as the slide before, and then you compare it to our national health expenditures. Again, this is public and private dollars. It's getting close to 20% of GDP, and you see where that money goes. You see that the vast majority of it goes to healthcare, to medical services, not to health. And we're spending 95+% of our national health expenditures on a factor that accounts for only 20% of outcomes. Other countries make bigger investments in other services, and they do it differently. We don't have to do it this way. Let me show you some data from the OECD. Next slide, please. Okay, so this slide has 25 different OECD countries. The green part of each bar, the bottom part, is the percentage of GDP that country spends on social services and social care, as they call it internationally. It includes things like housing. It also includes things like parental leave and PTO, all of the things that we think about as social services and as non-medical benefits go into that category. The top part of each bar, the blue part, shows the percentage of GDP that each of these countries spends on healthcare, on medical services. And what you see when you look at this chart is that we are spending, the US is the bar on the far right, we are spending far more than anybody else as a percentage of GDP on healthcare. And we are spending less than all but 4 others on social care. And what really jumps out at me is the ratio of spending between the two. We are heavily weighted towards spending on healthcare, and we are relatively underweighted in spending on social services. We are the opposite of all of these other countries. Let's take a look at what that has to do with health outcomes. Next slide, please. So this is the same slide as before, but this is the life expectancy for each of these countries. And you see that the relationship between our patterns of spending and life expectancy doesn't look so good. Next slide, please. Same thing, this is about obesity rate. We've got the highest. Next slide. Infant mortality, we're the worst. It doesn't have to be this way. These are choices we have made, and these are choices that you can help influence because you are buying health insurance on behalf of large numbers of employees. Next slide, please. And people get this. Texans understand the impact of social determinants of health. We do a lot of public opinion polling, and we did a survey earlier this year, a representative sample of Texans, and people get it. People understand that healthcare is really important, but that healthcare alone isn't going to bring them across the finish line. People don't know the term social determinants. That's a term that comes out of the public health literature. But when you start talking about what those determinants are, people get it. It's not that complicated. It's just that we are used to speaking in this country as if healthcare and health are the same thing. We use the words interchangeably. But if you break it out and you look at healthcare as just one factor whose intent is to increase your overall health, then you can distinguish between the two and get your head around thinking about health and not just healthcare. And your employers know this too. And as you purchase health benefits, you know it as well. And I know that all of you must have tried out various wellness programs with mixed results. Here are some opportunities to do things differently. Next slide, please. Actually, go on to the next one after that. So I don't have to tell you any of this. This is not new information to all of you, and it's why you care about your employees' health. We know that the unhealthy employees cost employers billions in lost productivity. We know that there are billions of dollars in costs for presenteeism, people who are showing up at work and they're not actually able to do the job. And this is in addition to all of the expenditures that you make on behalf of health insurance, workers' comp, disability costs. And so it's really important to you. Since you have robust medical plans, you also likely know the limits of what those plans currently buy for you as an employer and what your employers get as beneficiaries. Next slide. I'm throwing this in just as a great reference point, something I learned about actually from our staff as we were doing research to prepare for this. So the Health Enhancement Research Organization, some of you may be a member of it or a participant in HERO. It's a consortium of health and healthcare industry researchers and employers who are looking at these exact issues. And we know that employers are increasingly looking toward value-based benefit design strategies that bring together the opportunity to address the social determinants. Next slide, please. So I want to talk specifically about some of the social determinants that may be adversely impacting your employees, and that there are some things you can learn about it and some things you can do about it. And I've got some follow-up slides. So first, talking about safe neighborhoods, where you live is determinant of your life expectancy. And I want to show you an interactive chart in a couple of slides that will allow you to take a look at, from a heat map perspective, where your employees live and what their neighborhoods are like. Also, financial stability. We know that people who don't have enough money don't have the opportunity to buy the things that allow them to have a healthy life. We know from a GAO report that was released just about a week or two ago that, in fact, the biggest users of some of the means-tested government benefits for low-income workers are employees of Walmart and McDonald's. So there are a lot of employers who are paying employees in a way that makes them need financial assistance from the government. Next, food insecurity. We know that about 70% of the people who receive SNAP or food stamp benefits are full-time employees. And then lastly, the idea of social connections. Your workplace is a social connection. I know you've all seen this as COVID has disrupted the way we do our work. And something that I know my small employee group of 30 people has felt is we miss being together. And while there are some advantages to working from home, there's a loneliness factor that's in there. And as an employer, one of the things that you offer your employees is a place to be together with other people. And it's really important. Let's go to the next slide, please. So this is a replica from a map that is embedded in our website that you can go to. And what it shows you is what the life expectancy is in a particular neighborhood. And when you go into it, you can see that just across the street, there are vast differences in life expectancy just based on location. These are communities that many of you serve, but they're also communities in which you have employees living. So let's talk a little bit about how you might address some of those gaps. Next slide, please. So there's food. The Texas Medical Center went through a big undertaking to make sure that vending machines and food offerings within the Texas Medical Center became healthier, not necessarily by censoring what was offered, but by providing information that allowed consumers to understand the calorie count or the fat count or the carb count in the foods that they were consuming. The idea being, if you give people information, it can help them make healthier choices. There's also an increasing number of organizations that are creating food pharmacies where they actually are using food as medicine, particularly for employees that have chronic conditions like diabetes, where the food they eat really is like medicine. It can improve their health substantially. I put the logo for SHRM on here. I imagine all of you are members of SHRM, but they have a wealth of information about how you can use food in the workplace, including free food, and there are pros and cons on that. But if you haven't looked at food in the workplace as a way to improve your employees' health, then I would suggest starting with SHRM, and there's a lot of rich material out there. Next slide, please. So financial well-being, you can pay your employees more and that will improve their lives. We all know that, and there is a lot of data to go with it. So how do you go about doing that? One thing you can do is join the Living Wage Network, and that is a group of companies around the country who have said they want to understand what the living wage is, not the minimum wage, but a living wage for the employees in the communities in which they live, and they want to peg their own payroll to that schedule as opposed to a minimum wage schedule. There's also the opportunity to become certified as a B corporation. This is not an IRS designation. This is something that companies have gotten together to do to be able to work together to reward and then certify. It's in essence a good housekeeping seal of approval that you are exhibiting social responsibility, including towards your employees, by meeting certain goals and setting goals for yourself. We've got Tom's of Maine on here. You all know Tom's. They do the shoes, and you buy a pair and they give a pair away. But they also do a lot more than that. They peg their employees' salary above the living wage. So not just above the minimum wage and not just at the living wage, but above that. And they also encourage their employees to use some of their PTO, which is a health promoting benefit, to volunteer for organizations that they're passionate about. Next slide, please. So quick summary, you can have health promoting policies in your workplace. The way you design your benefits is critical. You can help your employees with courses in financial management, health literacy, so that they're making good choices. You can also give people paid time off. If we're talking to large employers on this call, you probably already have paid time off, and it is increasingly becoming evident that parental leave and other policies that give employees the time to take care of themselves and take care of their families are actually good for retaining and recruiting employees. And then lastly, your organizational culture. I talked a little bit earlier about social isolation and the importance of a community of support, emotional support, friends, people to converse with. You can enhance that in your organization by paying attention to your organizational culture and making sure that it's a healthy workplace in the sense that people feel comfortable there and that they do have a supportive environment. And it sounds really touchy-feely, but people who find camaraderie in their workplace are more likely to work hard and to stay longer. So let's move on to the next slide. Actually, let's skip to the 2 more slides. 1 more slide, please. Now I want to talk about what you can do in your community, because I think there's no backup one. There you go. And I want to try to put this into context. This is a graphic that came out earlier this year, and it really speaks to me because it talks about the different levels of intervention and whether they are more upstream or more downstream. And you see, if you start at the most downstream portion, you're talking about providing clinical care, doing medical interventions. And the reason that's downstream is by the time you're doing that, with the exception of preventive care, people are already sick. And so you've missed the opportunity to avoid sickness. The midstream part is where we do move upstream. We look at individual social needs. We don't just look at medical care. And the things I've been talking about in the last part of this presentation had to do with that. How do you enhance your own employees' health by doing things that are more midstream, that aren't just providing coverage for medical care, but that are actually addressing the non-medical factors. But you can actually go all the way upstream and have a community level impact. And as corporations, and particularly the larger ones of you, or where you are the big dog in the community you're in, you have some real opportunities to do good and do well at the same time. So let's go to the next slide, please. Okay. I want to talk about ways that employers can get involved in community. To solve these kinds of complex problems, there's not one sector that can do it. There's not one organization that can do it. We are increasingly seeing large multi-sector collaboratives that are trying to address serious problems. And I want to talk about 2 different ways that you can do this. There are many more than 2. One is the concept of anchor institutions. And that idea comes from the notion that if you are the big kahuna in your region, if you're in a small town, it's really easy to be that. Even if you're in Houston, you may be the largest employer in a particular neighborhood, or you may be the largest taxpayer in a particular neighborhood. You can take on the role as an anchor institution to convene others from other sectors to actually work on health-focused improvements for the community. Another model is the Texas Accountable Communities for Health Initiative, and this is on here because it's an EHF model, where we are working in 6 different communities. The only one in Houston is on the near north side, the others are in other counties. But these also are collaboratives that are based around a desire to improve the health in a particular community. And it's a great place for employers to get involved. Typically, the coalition leader in these ACHs it tends to be someone who's more directly in the health sector. Sometimes it's a health department, sometimes it's a community health coalition. But there's no reason employers can't be part of these. And I know these groups would love to have large employers because you think differently. You have a different set of resources. And I think you can add a lot to those conversations. Next slide, please. This is just one example of Campbell's and what they've done in essentially building a community collaborative. Now, of course, they're in the food business, so it makes a little bit more sense than for someone who's in the energy business. But the point is, any company can do this if they direct their social giving and their thinking about their role in the community toward community health. Next slide, please. me try to catch up with you. Okay, there's also opportunities to support safe housing. All of you are likely making investments, not necessarily through your employee benefit groups, but through other groups within your organization. And there are opportunities to actually make those investments count toward the communities. So there are community development financing institutions. Some of them are in banks and some of them are just independent organizations. Some are small and local and some are national, but they all offer opportunities for you to actually make an investment in community development. And it's an investment that returns financial ROI to you. And you can find one that is doing work in a neighborhood that you care about and supporting them. There are also, like the Houston Northeast CDC, those are community development corporations. They are similarly set up to help particular neighborhoods grow and prosper. And there are opportunities to work alongside of those organizations to find opportunities. The Funders Together to End Homelessness, everybody thinks this is about foundations. Well, sorta, but it's also about anyone who is investing in the community. You can invest in a way that actually improves the community by funding affordable housing. There are also examples like the Houston Area Women's Center, where you're really working upstream of homelessness, where they are providing shelter for women and their families who might be homeless if there wasn't a place for them to come when they're fleeing abuse and live there while they get themselves back on their feet. The alternative to the Women's Center is that those people become homeless or they stay in an abusive situation. These are all opportunities for you to work to improve the community. Next slide, please, which is my last slide. A quick overall summary of what you can do regarding social determinants of health. First, you can foster an SDOH-centric workplace culture. I can't overstate that enough, whether it's regarding food or the behaviors at work or pay time off. Fostering a community feel in your workplace and attending to something other than just the medical benefits really can go a long way to improving your employees' health. Next, and I can't emphasize this enough, you are buying insurance for tons of people. You should be able to influence the benefits that you are purchasing. Many of you are self-insured, so it's your buck. You ought to be able to work with the companies that are running your programs for you to build in social determinants benefits where you want them, and they can administer that for you. They will do what you want them to do, particularly if you're a large employer. But if you keep on saying, I'm just buying medical benefits so people can go to the hospital, they'll just keep giving that to you. So I would suggest you talk to them about developing benefit plans that incorporate social determinants benefits. And lastly, to the last points I was making, you have company-wide charitable efforts. It's probably led out of some sort of public relations or community investment group, and maybe not in your health benefits group. But if you partner with them and introduce them to the concept of, rather than just putting money out there to nice groups who have nice luncheons or a fun run, that you might actually direct those charitable investments and the actual financial investments for ROI into things that improve community health. And with that, I'm going to stop and turn it over to the next speaker. Again, thank you so much for letting me have the opportunity to address a really different audience who's so influential.
Elena, thank you very, very much for that. I know I learned a lot and wrote down quite a few things here. So I look forward to our panel discussion. I suspect our audience has questions as well. So what we're going to do now is we are going to shift from Elena to Jessica. Jessica, if you can start your camera. Thank you. So again, I've known Jessica for several years right now, and from day one. In fact, the first time I ever heard of SDOH was at a National Alliance meeting in Ohio. I just remember that, and I was ignorant. Jessica has been in this space for a lot longer than I, and I thought it would be helpful for Jessica to share with us her experiences in the employer community, both in terms of challenges that she has found, but also in terms of opportunities, and may be able to share some practices that some of her employers have utilized, or at least trying to move forward. So with that, Jessica, it is your stage. This is good. You have no slides. You're just going to talk from the cuff, but you let me know when you're ready, and we'll start with you. And when you're done, you let me know, and we'll figure it out. Thanks, Jessica, so much. I'm going to depart here.
No problem. You can hear me okay, Chris?
Good. We can hear you great, Jessica.
Okay, good. Well, thank you all. Thank you, Chris, for your leadership and willingness to do what it takes to go from well-being in the definitions you gave earlier, were very clear, to well-doing and the intention of well-doing. It is my honor to be here in this dynamic coalition world with you, and I learn a lot from you every interaction we have, so thank you for your leadership. And Elena, you shared a great call to action. You gave very practical way that employers can activate their roles as community members in an even more intentional way around social determinants of health. One of the quotes that I wrote down was, "Duh, you can pay your employees more and that will improve their lives. Join the Living Wage Network." Clear call to action, and very upfront, and very clear about you can play an active role around these social determinants of health issues. Another point you made that I think is noteworthy and may have been missed is that a good percentage of our employees in our workforce are on SNAP benefits, making it clear that these are workforce issues. This isn't the Medicaid plan issue. This isn't the plan down the street or the community issue, the public health issue. These are workforce issues. Our workforce are needing social services to be able to meet their basic needs, and that's important for employers to understand. And to me, it makes a clear case that why wouldn't we be in and prioritize the social determinants of health culture and strategy? So clearly, Houston, you have the ingredients in your coalition leader, and Chris, and leaders such as Elena, to be an example for the country. And so thank you for having me with you today. So here in Pittsburg, Pennsylvania, I wish I could do a panoramic view. We just had our first snow here yesterday, 4 to 6 inches. What a way to bring in the month of December. I was super excited. My husband, on the other hand, was not so much, as he's the one shoveling the snow. But there's nothing like the first snow of the season, and it brings me really great joy. And I'm sure there's no snow in Houston at this time, but probably a little bit warmer than it is here. A little bit about me, outside of liking snow. My favorite month is May. Random fact, I know, but I'm going somewhere here. It's the month my husband and I met, May 1st. We married the following May on the 28th. We had our first child the very next May, Jace, on May 14th. Chris has actually seen me have, I think, 3 of the 4 kids. So as you can imagine, we expect great things to happen in May. And this May, however, was different. We were still at the height of the COVID-19 pandemic. We were stuck in the house with our kids, happily and joyfully, if you can believe that. For almost 2 months at that point. And so being in the business of healthcare, our worlds were already turned upside down. And now we were teachers and facilitating classrooms inside our homes simultaneously. So we figured as it neared our wedding anniversary, it was likely going to be uneventful and guaranteed to consist of a quarantine. But then those 8 minutes and 46 seconds happened on May 25th. In those 8 minutes and 46 seconds, our entire world changed. Our world is meaning my husband, my children, our world changed. And the world changed. We held onto each other really tight. We held onto our kids even tighter, especially our Black sons. And through the pain and admittedly some fear, we were compelled to act, leverage every platform we had in our reach to finally confront the reality of racism. At this point, we found ourselves in not one, but two pandemics. One that had been going on a lot longer than before March. And we weren't alone. The world was in this with us. Many asked, what can I do? What should I do? And some did. Some identify as allies, some as advocates, and some as activists. No matter the title, activation has been called for. As CEOs and politicians responded with statements and proposed positions on these matters, our medical community across the country kneeled for 8 minutes and 46 seconds on hospital lawns. There were new hashtags created, hashtag white coats for Black lives. This was a message to dismantle racism in medicine and promote the health and well-being and self-determination of Black and other people of color. This was huge, a big deal. Why? Since late March, we read headlines across the country that highlighted grave disparities in COVID-19, that it was disproportionately killing Black and brown women and men. Yet, there weren't white coats kneeling on lawns until June, after the murder of George Floyd. This system, called the healthcare system, for maybe the first time, went beyond studies and research and humanized the injustices that have plagued our healthcare practices, policies, procedures, which have done and is doing significant harm to many. This was a symbol of we see you. We are all in this together. We will do our part to ensure we no longer do you harm. As healthcare providers united, the business community began to write statements and make millions to even billion-dollar commitments to dismantle racism. From affordable housing, Elena mentioned a lot of these opportunities to make commitments to that we need in our social sector, to lending practices. If you were in the financial sector, banks actually facing their role in redlining and addressing their impact on the lack of generational wealth being transferred for generations in certain communities, to educational investments, to increased commitments to working with small disadvantaged businesses, those who also were disadvantaged even more so by not receiving PPP loans and grants, being eligible for the EIDL loans that were given and provided during COVID-19, yet even more disadvantaged now more than they were before. This was the business community sending a message from the top. We are all in this together. You are no longer alone. We, as a business community, we see you, and we will do our part. Again, for the first time, a collective of some of the largest employers in the country, from Ben & Jerry's, the name brands that you may have in your fridge today and freezer, to Bank of America, humanized the racial injustices that have plagued corporate cultures since the inception of employment in this country. This is major. So, how do we go from kneeling statements and multi-million-dollar commitments to aligned causes? We choose to. That's the answer. Make a choice. Not only is this an opportunity for employers to be a part of the solution, this is the responsibility of employers to be a part of the solution. COVID-19 stripped any ideals that we stay in our lane as employers, as we like to do. Employers instantly became public health officials. I can't even imagine employers saying we're not in the business of public health at this point in time. From being COVID-19 testers and contact tracers, if blinded on some phone calls, I'm sure you wouldn't be able to tell if you were speaking to an employer at times or a county health department. We are in the business of public health. Without employers being active, we would not even have the progress that we have made during this pandemic. So with this said, we can quickly fall into old habits and put things back in their usual places because we're tired. We're tired of feeling uncomfortable. We've been uncomfortable for months now, many for their whole lives. But some of us just for a few months, and we're tired of it. However, in these moments, I ask you to lean in even more diligently and deliberately because lives are literally at stake. And although employers aren't amputating legs or positioning a scalpel or doing a CT scan themselves directly, you are spending millions and billions of dollars collectively on the access to those services, to those procedures, to those experiences. So we cannot unlearn what we learned over the past few months, that Black and Brown people died at 3 times the rate of their white counterparts due to this pandemic of COVID-19. That Black and Brown people were more likely to contract the virus at even younger ages than other races. That these are our workforce, these are our employees and our families and our community. That Black and Brown people were adversely impacted due to conditions such as hypertension and diabetes, and I know obesity on the agenda today. And these were health disparities that existed well before this pandemic, and they're not only due to what we like to think are personal choices. Many of those things Elena mentioned to you today play a major role in why we have diabetes and access to high sugar foods and less nutritious foods and certain food desert neighborhoods or transportation issues that don't allow us to get to the adequate care, even our medical care to manage our diabetes. There's a lot of reasons why. So please do not be quick to point the finger and say, well, that's a personal choice. This goes beyond social determinants of health to the root cause of it that created the reality that we have today in this upstream opportunity. Cancer outcomes are worse. Cardiovascular outcomes are worse for Black patients, for example. Black moms, we have a maternal mortality crisis in our country for white moms and Black moms. However, Black moms are dying at 3 times the rate than their white counterparts. And then when you account for income and someone such as myself, and when Chris jokes and says he's seen me, pretty much have 3 kids or pregnant at least 3 times, I take that as a blessing. I'm lucky to be alive. I live in a city that has been named the worst city in America for Black women to live. We have some of the worst maternal mortality rates in the country compared to 89 comparable cities. And I'm alive today. We have some of the worst infant mortality rates than some of our counterparts, most of our counterparts in the country. 89 comparable cities. We're in the bottom 3. So my children are blessed to be alive today. These are real issues. Women and women of color are more likely to be misdiagnosed and have delayed diagnoses than men. Medical students believe, as a recent survey of 2016, that there are biological differences between Blacks and whites, which result in poor pain management and treatment disparities. Doctors may be trusted more than maybe the facilities, but they're at risk of closing due to this pandemic. So these compounding effects will have detrimental outcomes if we do not step up and make this a priority. So the list can go on, and I can list a lot more disparities and talk about the many layers and intersections. But why are employers still needing a business case and blood samples to validate their roles in health equity and social determinants of health? Why is this still a question? I honestly believe it's because we don't exactly know what to do. One reason is because we are leading with limited to no visibility into our own issues within our workforce. However, I just spit out of several different stats and issues that we do have access to. However, we don't see our own data. And as I've spoken to employers, most of them say they have known about health disparities, but outside of that reality, didn't think it impacted them and their workforce for various reasons. Some because they don't have a very diverse workforce and they don't really collect the data of the families and spouses and children who may be diverse. Others because they truly believe their rich plan design results in the optimal treatment for their employees. But bias doesn't care about your copay amount or your out-of-pocket maximum. As we unpack these conversations, it came down to what can I do if I don't have the data? Yet I'm also scared of having access to that data. We have to make some choices. The other comments were, my employees and family members don't share these stories with us. We don't hear about it. The mom who died shortly after childbirth because she was ignored or disregarded, we don't hear about it. We don't hear about the pain mismanagement because the doctor believed his nerve endings were less sensitive due to his race. We don't hear about the sister who is a diabetic but had a preventable amputation when a certain therapy, which is offered more often to her white counterpart, wasn't an option for her to consider. We don't see the trends that certain demographics of our covered lives realize a different value in our health plans than others with the same level of access. Employers said, where are these stories going? Who hears them? How can we find out so that we can play an active role and a better role as an advocate? And in order to have a comprehensive discussion on social determinants of health, we must include the discussion on health equity. In order to discuss health equity, we must discuss race equity. And what is that? It's the condition where one's race identity has no influence on how one fares in society. Health equity can only be achieved when one's race identity has no influence on how one fares in our healthcare system. And according to the CDC, it's achieved when every person has the opportunity to attain his or her full potential, and no one is disadvantaged from achieving this potential. Employers, when asked if you are okay, if your white millennial employee who is pregnant and your Black millennial employee who is pregnant, both due at the same time, both in the IT division, both similar incomes and the same plan design and access, they go to have their babies and one doesn't come back because she's dead. And she's dead due to embedded bias in the system. Is that okay, employer? I asked that question to my board of directors, and the answer with no hesitation was, of course not. That's not okay. This is why we need to step up and figure out our role in this. And my response is, well, then it's better you assume that that's the reality or a likely reality for some of your population, and you have a role to play to address it. Assume bias exists in your healthcare ecosystem, in some of your decision making, and not acting upon it makes you a part of the problem, because the lives depend on you not ignoring that possibility. And beyond it's the right thing to do, large portions of our community members are at risk of adverse outcomes or even death if we don't focus on these issues. in the issue of health equity. We must see health inequity as an insidious injustice on humankind and look at it comprehensively from an affordability, quality, access, equity lens, from behavioral care to preventative care to traditional medical interventions and RX innovation, and now a digital and artificial intelligence health perspective. And like many other things, social injustice issues that have hit not only this country, but our own cities and our backyards, including mine, ultimately impact all of us, one way or another. We have all been disrupted by George Floyd's killing, for example. Across the country, the like social injustice, health inequity seeps through its intended confines and impacts poor patients, our elderly, and yes, white men also at times, because the practices have become a part of the culture. We are all at risk if we do not activate today. So I know there's so much more I can add, and I believe I'm at time, and I'll share many of the examples on what we can do about it in our panel discussion. So I'll save that for then. Thank you, Chris.
Wow. Well, Jessica, I've heard versions of your comments before, but I was mesmerized, as I suspect most of our audience was. So what I'd like to be able to do now is ask Dan Burke to put on his camera and mic. I'd like Heidi McPherson to do the same. I'd like Dr. Rupesh Nigam to do the same. And this will be our panel. There we go. There we go. So, and Elena, we forgot about Elena. Where's Elena? Sorry, Elena. There we go. Sorry about that, Elena. So for the next 30 minutes, just wanted to hear some comments and then pose some questions, and then we'll see if we have anything from the chat box. But very powerful discussions this morning. I'd like to start with Dan Burke and get his thoughts on what Elena and or Jessica has said. Dan, by the way, is the Director of Benefits with Turner Industries. They're in many states in this country. Dan is on our board, and he will actually be our board chair beginning in January. So Dan, just want to start with you. How did the comments of Elena and Jessica resonate with you as a large employer, 20,000 some employees, and how does it match things that you may be doing or may not have even considered doing?
Yeah, well, thank you, Chris, and thanks to Jessica and Elena for getting us off to a great start. Now, admittedly, Turner Industries had been fairly unsophisticated with regard to how we handle social determinants of health going back 2 years ago. So we've begun to develop some things to address our workforce. And to Chris's point, we have over 20,000 employees in about 40 states. We are heavily concentrated in the Gulf South, so Louisiana, Texas, Alabama, Mississippi, Florida, where the bulk of our employees are. And at the end of the day, what I'm hearing here is really encouraging, because I realize that I've got so much to learn and so much to be able to implement with our workforce. And the work that our employees do, we're an industrial contractor, so we work in refineries, petrochemical plants, and pipe fabrication shops. So we have a broad range of employees that are at various income levels and reside in various parts of the country. But what we learned back in 2019, when I first started to look into social determinants of health, is that we could really begin to incorporate aspects of social determinants into our population health management program and start to use that as a factor to help our employees improve their health and begin to get them more access to care. So really for us, the cornerstone of our population health management program is a nurse navigation program that focuses on health coaching of our employees at the job site. So we we partner with hospitals and health systems at the local level to go in and assist our employees with any health issues that they may have. And those are direct contracts with health systems that are performance-based. And at the end of the day, these are focusing on folks with diabetes and hypertension. So when Elena had mentioned some of those conditions in her early remarks, that really got my attention. So really, what we've done back in 2019 was we started to look at social determinants such as what kind of data do we have? All right, we've got home addresses and zip code and salary level. Are people participating in our 401k plan? Do they have a loan against their 401k plan that would indicate some level of financial distress? We started to incorporate some census data to identify zip codes. Here in Baton Rouge, where we're headquartered, we know the zip codes where people may not have access to care. People may not have access to reliable public transportation. They may not have access to good food sources and grocery stores. So we use that information manually and fed it to our analytics vendor, who takes our health claims data and also had used some predictive modeling software to begin to predict when employees may have a hospital admission, an ER visit, a cardiac event of some sort. And this can really help bolster that information. And it gives our health coaches a good roadmap to understand who they needed to engage with when they went out to a job site. Now, armed with that information, it can be really useful. So that's, admittedly, it was unsophisticated in 2019. 2020, we're starting to take some additional steps. Our analytics partner has actually incorporated all of that information that I referenced earlier. So salary information, zip code, 401k participation, 401k loans, are you in the long-term disability plan? Those are all factors that are incorporated into the predictive risk score for all of our employees, which is provided to our nurse health coaches, and that can help them triage and understand what people they need to prioritize for intervention and conversation. Now, granted, the pandemic has slowed that down, and actually getting to job sites has become really hard. There's a lot of this virtual back and forth, a lot of communication that is done via text message or phones. So that has been a real improvement. It's no longer a manual process where I'm kind of driving a lot of that and looking at the information that we have. It's automated through our analytics partner. Another piece that is worth mentioning here is what we are doing from the communications front. So anytime you talk to an employer, and I'm sure Chris and Jessica, you would probably echo these sentiments, the first challenge that we have is health costs, right? The second is communicating to our employees about health insurance and benefits and how things work. Now, one thing that we've tried to do over the last 18 months or so is improve our communications to be a bit more focused, a bit more easy to use for our employees, so meet them where they're at. So we're trying to be more mobile focused, sending out short videos and short text messages through a mass text message system that is aimed at really improving health literacy. So trying to educate people on, okay, what's a deductible and what does it mean to me? What are copays and what does that mean to me? When can I expect to pay a copay? If I've been diagnosed with COVID, what can I expect? So those bits of information have been a lot more prevalent for us over the last 18 months. Other ways that Turner is trying to be a bit more proactive in social determinants and being a good corporate partner. We're a huge partner in United Way here in Louisiana. I have taken a leadership role in taking aim at cancer in Louisiana, which is an organization that was spearheaded by our governor and has since morphed into a nonprofit. It aims to improve cancer outcomes and reduce racial disparities in outcomes across the state. And like most things, Louisiana, we rank 48th, 49th, or 50th in health outcomes due to cancer. So there's a lot of room for improvement. And that's been exciting for me because I'm the sole employer voice on that board, which is its health systems, its payers, and it's the state government. So it's been fun, but you know, we definitely I realize after sitting through the first hour of discussions with Elena and Jessica that I've got a lot more to learn, and there's a lot more improvement to be done. So didn't mean to filibuster, but I kind of want to hit on some of the things that we're working on social determinants.
Yeah, I mean, this could be a day-long discussion. We don't have a day, but maybe down the line. You know, I'd like to next go to Heidi McPherson. Heidi is responsible for a lot of the community outreach through the American Heart Association. She is also on our board, but as important, Heidi leads what's known as it's a mouthful, the Greater Houston Social Determinants of Health Collaborative. And it's about 75 organizations in Houston. We try to represent the employers. There are other employers, but Heidi, I'd like you to respond and on the work you're doing. How does what Elena has said and what Jessica has said help you coalesce and merge what you're doing through the coalition?
Hi, thank you, Chris, for the opportunity to share some of the work we're doing and really hopefully help connect some of the dots. It was really exciting to hear Dan's journey and the work at Turner Industries of aligning different efforts with social determinants of health. As I was reflecting and preparing for this morning's conversation, really thinking about the role of employers and how much opportunity is there, and that perhaps some of those dots are not being connected simply because of the language of public health. And having this conversation a little bit more intentionally, we can better align some of the many efforts that are underway and be more effective together. With the American Heart Association, I've had the opportunity to work with many of the major employers across the greater Houston region, and hearing them talk about their employee populations and how do they build a culture of health internally. Often they would talk about the variance across their employee populations of those within the corporate offices and those within the field offices. You know, Houston, we're of course very much oil and gas. There's a lot of other things, but a lot of that. So there's a lot of people in the field and vast disparities in health outcomes, and then in the from an employer role, the engagement. And what was there? There was a lot of questions around that. And the more that I've spent over the past couple of years, I've spent time looking at the social determinants of health and really understanding what is upstream. Elena used the word upstream, and what does that mean? That's really a public health short story of somebody pulling all the children out of the river as they're going over the falls. And they're just focused on pulling them out. And another person comes up and says, well, why don't we go upstream and see what's making them fall in the river in the first place and try to stop that? That's a little bit of what we need to do, I think, as employers and as companies in our communities. Jessica did such a nice job of really connecting the dots between the social determinants of health, so to speak, and health equity and the disparities across our populations. You know, in the work that I do with the Greater Houston Coalition for Social Determinants of Health, it's a growing effort. It's a collective effort. These types of things, they're societal. How do we make our communities and our societies more effective, more healthy, more vibrant? How do we grow the vitality of the American way of life? There's a lot of opportunity there as we connect some of this science. And one of the key things is we've got to come together. We've got to work beyond our organizations, beyond just those organizational goals, in order to actually exceed our own organizational goals. That's a new way of working for a lot of people. But that's where we come to these coalitions and these collective efforts. Houston has a very robust work. So for those of you in the greater Houston region, of which I know many of you are in the audience, I encourage you to connect to the conversations, understand how we're changing the systems together and how you can contribute to that. And how might you invest your resources to have a better impact or a more effective impact. You know, one of the things we see around our community is our Sparks Parks. And those are so important for our neighborhoods and our communities. How do we think about doing that in a little bit more systemic way so that there are access to parks and trails and sidewalks in all of our communities? That's just one example of how we go a little bit more upstream together and build the system so our communities are set to be healthier, where everyone feels like they can get outside and be active and physically healthy. And, you know, in addition to a coalition that's very much focused on social determinants of health and how do you build the systems for organizations to work together, measure the impact of what they're doing together with the healthcare sector and the community sector, and tell the story of how that's important for an employer. There are several other coalitions. You know, Jessica mentioned maternal mortality. We know here in Texas and here in Houston, that is a crisis. There's coalitions and efforts there. I think about even the work that we're doing here in the Houston Business Coalition on Health and some of those pieces that came up on safety aspects of our healthcare and our purchasing power of changing the way that our benefits designs are accessible. Some of these social determinants of health risks for populations. The HBCH has some very robust efforts that are aligned with that y'all can get involved in and really shape some of these offerings. So with that, I'll pause. I know that that's a lot. There's a lot of opportunity, I think, is the takeaway. So understanding what aligns with your business and where you a little bit.
Sounds good. Heidi, thank you so much. There's a good reason that I have Dr. Rupesh Nigam with Kelsey Siebold on the panel. HBCH has an excellent relationship with Kelsey Siebold. We're aligned in a lot of different areas. But I attended a webinar the other day about a product offering that Kelsey Siebold is going to have for all of their attributed members in their ACO. And when he told me about this, it relates to Elena's comments about providing some midstream support. So Dr. Nigam, if you could just for a few minutes tell us what you're doing, and I think it's a model that other healthcare delivery systems, they may already be doing it, but I was just very impressed with what it was. Can you talk about that for a couple minutes?
Absolutely. Good morning, everybody, and I'm thrilled to be able to speak to all of you on this esteemed panel. And Elena and Jessica, what can I say about your presentation? At midpoint, I had my hair standing on my hands. It's just so powerful what you guys are talking about, and so close to what we have been doing here at Kelsey Siebold. I should perhaps start with giving you a brief introduction about what and who Kelsey Siebold is. We are a large ACO in Houston. We've been around for about 70 years. We are about 500 physician group, and we have all specialties. About 27 clinics throughout the city of Houston. So we have outpatient services as well as hospitalist services in the medical center and around greater Houston. As I said, we have specialty services as well. So we do provide all levels of care. As far as, who do we care for? We have our own Medicare Advantage plan, Kelsey Care Advantage, which has been 5-star for the last 5 years, which is a pretty big deal. And we have capitated arrangements with a lot of large employer groups. So I'm pretty sure that some of the folks who are listening in on the webinar perhaps come to Kelsey-Seybold for their care. Having a capitated arrangement and having a risk on patients gives us the opportunity to look at a much global perspective of their healthcare. So it's not episodic care that the patient is coming in for. And with our health plan partners, and particularly being on our own MA plan, we have access to data of utilization of what kind of services has the patient utilized. So how much home health care, how much skilled nursing facility, how much of durable medical equipment has the patient to utilize. And based on all of that, much like what Dan was saying, we are able to kind of form a picture of a patient's requirements in total health care. Now going back to what prompted us to start this population health program. Well, you guys have all been to doctor's offices. If not, then you should. Go get your preventive health care done. But with our best intentions, the maximum time that we'll spend with you is about 30 to 45 minutes. That's tops. Otherwise, it's usually a 15 or 20-minute visit to a doctor's office. And God forbid, if you are in the hospital admitted, the time that a doctor spends in your bedside depends on, what all the doctor has to perform. And again, it's not a large amount of time. How much can we, as physicians, really tell about a patient in that 15, 20-minute interaction? How much can we tell why is the patient coming into the hospital again and again, or seeking their primary care in the ER, or not coming to the doctor's office? And as Elena's presentation pointed out, a large portion of that lies in between, what happens between the two visits to the doctor's office. And all of that is happening outside of our view, or was happening outside of our view. And this did concern us. So about 2 years ago, close to 2 years ago now, I launched this population health initiative at Kelsey-Seybold as a provider. With all of our attributed lives, much as Chris said, what we did was we divided Greater Houston into 5 zones, 4 directions and 1 central, and we assigned a team of 2 nurse practitioners, LVNs, MAs, social workers, dietitians, pharmacists, and behavioral health therapists to be assigned to patients. We started with going to patients' home. How did we choose the patients where we would start the visit? Well, we go back to the data. We look at which patient has been utilizing ER services more frequently, which patient has been admitted to the hospital more frequently, patients whose hemoglobin A1C, which is a measure of the diabetes, is over 10, which patient is responsible for the top 5th or the top 10th percentile of the healthcare dollar spend on an employer's plan. And these are the few measures that we looked at. And then we looked at these patients, and the initial visit was done by a nurse practitioner in the patient's house. That was just to establish a rapport, get baseline vitals, understand what the patient's healthcare needs are. And then subsequent visits were done by dietitians, by social workers. And once the rapport is established, and we are there by the patient's bedside or in the patient's house, we were able to talk to them and have them show us what kind of foods they were eating on a day-to-day basis. What is in their pantry? Are they getting DoorDash for every meal? Or are they eating canned food? Healthcare literacy is very important and unfortunately very frequently overlooked at. You might think that you're eating green beans, but if the green beans are coming out of a can, they are loaded with salt. You might think that eating a banana and an apple is healthy, but if you're a diabetic, that's a lot of carbs. So just those simple things makes a big difference in the short and the long term for a patient's health. And I'll give you an example of a visit that we just did. Today is Wednesday. Last Thursday, this is a very well-educated young executive who had a difficulty in his food pipes swallowing food, and it got dilated, treated once, and then the patient was back attending all these, fancy restaurant meetings and eating big steaks and whatnot, and the problem just kept on recurring. All that needed to be done was we needed to educate the patient to take smaller bites, and the food would go down easier. And just that simple thing to a well-educated executive. I mean, you would not think, but those are the kinds of things that I'm just giving you an example of what we can do when we are sitting down in a patient in their own environment. And going back to what this discussion is all about, food deserts. You all know. You've heard that term now. There are a lot of food deserts in Greater Houston, and that does have a very direct implication on a patient's health, and particularly over this last year with the pandemic, with people just not being comfortable going to the grocery stores. How are they getting food? What kind of food are they getting? It's just these simple things. Patients' medications, they're not going to pharmacies. How are they refilling their medications? Stuff like that, which as a provider, we can look at. And then with our ability to provide services to these attributed patients where we can innovate because we are not restricted by who's going to pay for the services, because we are capitated. We are responsible for the patient's health. We can set up, free drug delivery to the patient's home. We can set up visits to the patient's house to take care of the diabetic foot. Chris, you tell me when to stop. I love talking.
Yeah, well, I think we get the gist of what that is. We have a few minutes before we get to our next panel, but a couple things. I think there's a lot of opportunity here. I shared with Elena the other day. One of our former board chairs said to me when I first came on board, every one of our companies cares about people. They give these funds to many different causes, but it's diffuse, and so you don't really see any measurable impact. And his comment to me was, if we can come up with some type of an initiative in our market that would benefit the greater community and the employees, they would line up to help support this, both in terms of actions and in terms of funding. So I heard yesterday, and I heard again today with Dan, perhaps some mapping. I don't know if employers have gone through what Dan has. They know we have the addresses. If employers can together, many employers, say in the ship channel area, look at where their employees are, and then collectively support the needs of those communities together, that would seem to be good. Another thing, we tend to say, well, we're the energy sector, everybody's paid a great wage. Well, they may, but keep in mind that they're getting paid, but still most folks, no matter what wage scale, have not had much of a salary increase over the last 15 plus years due to rising healthcare costs. So again, maybe purchase health and not just health care as an example. I think we've gone as far as we can with high deductibles. There are many studies that show that has had an unintended consequence. Instead of promoting consumerism, especially with the lower wage folks within well-paying industries, they're just not getting care, and chronic conditions mount up until you wind up having a catastrophic event. So things like reducing copays for specialty drugs based on your salary tier, things like having variable premiums. Some companies are doing that. There's a lot of things that employers can be doing in this regard. I appreciate the comments on health literacy. That is so critical. There are so many opportunities for employers to support health literacy. We've been pushing that, but it hasn't received as much traction as I think it can. So I think this is the beginning of this discussion and not the end. Based on what we've heard here, I'd like each of our panelists to provide some closing comments, a recommendation, a thought after hearing this. So Elena, you started, so I'm going to start with you here again. Your comments.
Thanks. I'm so glad we heard from the doctor, from Kelsey. Y'all are amazing. You were the first to have to realize, even within healthcare, that healthcare is like this integrated thing. For those of you who are purchasing health benefits, when you are buying fee for service, you are going to pay for volume and you're not going to pay for outcomes. When you work with providers, large and small, that are willing to take on capitation and take on risk, they will produce better health outcomes and they will use the tools that are most effective. Your comment, Dr. Nigam, about the visiting people's homes, giving instruction, that's common sense. He's not getting paid piece by piece for that, but he has incentive to do it because it's actually cheaper than having the person come in for another visit or another scope. And if you, as purchasers of health insurance, will incent the providers to deliver health outcomes instead of delivering specific services, you'll get better outcomes for a lower cost.
Thanks, Elena. Jessica, how about you?
Sure, happy to. I think we've traditionally, as employers, have really done a good job of focusing and applying equality, but not equity. And as a result, we have significant disparities that exist. And so we're going to have to put disparate efforts and attention into certain areas and certain people to ensure that we actually achieve equity. And that does mean looking at your data and your people differently, looking beyond the claims and trying to understand the stories behind those claims, and rehumanize those claims so that we can actually impact the lives. Our employees are aware. They're scared. They've read the headlines too. They've seen CNN and other news stations, talks, and understand these disparities exist, and they have personal stories, and they've seen it happen to someone they loved if it wasn't themselves. And so know that, and then try to do your best to understand those stories and put disparate effort to actually realize equity.
Yeah, what I got out of a lot of what you said is the need for employees. They have an opportunity, but they have a responsibility, I think, to look at this a little bit deeper with their own data. And you know me, I'm the data guy. So I think there's some opportunities here, and I'd like to work with you a little bit more to help drive this in our market. Dan, how about you?
Well, first off, Dr. Rupesh, I'm stunned to hear that you guys are doing house calls. That's certainly something before my time, but it's really exciting to see and to hear talk of capitation. That brings me back to a point in my career where I had a lot more hair on the top of my head. And I think that we're moving towards capitated agreements and capitated contracts between employers and providers, and that's an exciting piece of the puzzle, to Elena's point, that a lot of us can explore. One of the things that I plan to really focus on is, I talked earlier about how we're incorporating components of social determinants of health into our predictive risk model at a global level. We know that healthcare is very local, so what may be effective and what may be a factor here in the Baton Rouge market or in Corpus Christi isn't necessarily what works in Houston. So Chris had mentioned a heat map. I would really like to get a look at the Houston market and see where some of the issues lie when it comes to social determinants specific to the Metro Houston area. Our employees work in Deer Park and Pasadena and League City and areas where there are refineries and not great environmental conditions. So that is really, I think, something that I can take away from this session is let's focus on the Houston market and really incorporate the social determinants there to have a positive impact on our community. Really learned a lot from this session.
And then with Heidi here, and I know that was music to her ears because we have heat maps showing where diabetes is in our market. We have heat maps showing where there are food deserts in our market. They really overlap one another. You saw that graph that Elena provided, you know, life expectancy, it corroborates all of this. What we don't have, or at least I haven't seen it, is that heat map of where are our employees and what can employers do to their own benefit and for the community. So Heidi, your thought on that?
Yes, entirely, Chris. You know, when you look at the maps of Houston, and I've spent a fair amount of time looking at lots of different health-related maps, there's a backwards moon shape across the Houston area that has poor health outcomes and low access to health care, to healthy foods, to parks. It's kind of across the board. You see the poor health outcomes and poor community resources just generally aligned. And that's where there's a key opportunity for us as employers to look at how do we provide those opportunities to those who have lower resources themselves, because that's also where the poor populations are living. There's just a lot of opportunity. I would say, you know, just to follow up, our almost responsibility is to figure out how do we add value? How do we add value in our community? Primarily as an employer, you're offering a means, right? And you're offering jobs, and that is a key piece of our community. How do you connect then? How do you reach out and understand what are the efforts that are happening in the community? I encourage you, I welcome any of you to reach out to me and connect to the different collective efforts. You don't need to go remap Houston, it's been mapped. Those of us who have been working in it can help connect you to the opportunities that align with what resonates with you and your employee populations. And you can connect there, add value, see where you can contribute and help us be more effective and healthy together.
Thanks. Yeah. So this is fantastic. Rupesh, I'm going to end with you, but by the way, I was on a National Alliance call yesterday, or webinar, and those in the healthcare industry are probably familiar with the advisory board. And it's a think tank, if you will, for healthcare delivery providers, health plans, hospitals, etc. And their CEO, Ford Coles, was our keynote yesterday, and he was talking about opportunities, and I knew we were having this today, and he was talking about the real opportunity for capitated models, and it aligns with several of the things we're trying to work through here in Houston. Working with ACOs is a key initiative with us. Advanced primary care, we've heard so much about that. That is a key initiative for HBCH. So lots of opportunities to get engaged. Rupesh, your thought here.
Well, first of all, thank you, Chris, for having me last on the list. I get to refer to everybody's wisdom, having heard what Pearl's people have been talking about. So one thing that I want to tell you is that the maps, you know, we all have maps, much as Heidi said. And Chris, you said that, you know, you could see the overlap. As providers, we have data on where our patients live. And there is an absolute overlap to Elena's map about the life expectancy, to what Heidi's referring about, you know, food deserts and where there are lack of parks, what you know, what all of us are talking about, and what Jessica mentioned about the disparity as far as it's related to, various races in Houston. We have areas where there are, particular ethnicities which are localized, and we can see the disparities. It's pretty evident. Coming back to the capitation piece, I'm going to go ahead and make a semi-political statement, but I guess we cannot wait for the government to enact laws where, the doctors are able to provide care for these social determinants of health. We have to be able to innovate, and our ability as providers to innovate comes when, we have this capitation model where we are not tied down to who's going to pay for this service, who's going to pay for that service. We can innovate. We have been innovating. And Dan, home visits are very close to my heart. I've done palliative care and supportive medicine at Kelsey as well. And as what we've been talking about, to make that connection, Jessica, to the patient, it's nothing better than sitting in between a family and talking to them and understanding them and making that connection to where they're calling us before they're calling 911, because they know that they really don't need to go to the ER. So is there another way that they can get the health care? And they don't feel well enough to come to the doctor's office. So again, I go back on the provider side, but these connections, we can make those and we can innovate because of what Elena mentioned, our ability to innovate and capitation and being at taking risk on the healthcare for the patients.
Well, Dr. Nigam, Elena, Heidi, Dan, Jessica, I mean, I just thoroughly enjoyed this. By the way, this is recorded, so it will be available, and we'll put some things out in our newsletter that relate to that, our weekly newsletter. So again, thank you so much. What I'd like to do now is to ask all of our panelists to mute and take their camera off. We'll go to the next slide, and we'll introduce Dr. Courtney Walker here. And Courtney, if you can put your make your camera live from there. And Dr. Nigam, you can take off your camera right now. Thank you. So good morning, Courtney. I'm so glad you're going to be with us. Now, I've known Courtney for a few years here. He is a medical, he's a PharmD. It's PharmD, not PharmaD. I don't know how that wound up on the slide, but it's PharmD with Novo Nordisk. And I asked Courtney to speak. Novo Nordisk is extremely big into obesity prevention, obesity treatment, continuity of care. I asked Courtney to not necessarily speak about the pharmacological impact, but I asked him to speak about what we know about obesity as a social determinant of health, and we can cross the line to racial equity as well. So Courtney, I don't know if you're going to drive or Sam is, but it's all your show right now, and look forward to hearing what you have to say. Thanks, Courtney.
Thank you so much for this opportunity. First slide, please. I want to say thank you so much to the excellent speakers who spoke before this morning. It was a phenomenal presentation. It is an honor for me to be here. I'm an alumni of the University of Houston and Texas Southern University College of Pharmacy. So Houston has a warm place in my heart. Plus, we love the restaurants there. It's a great place. So it's an honor to be here this morning. First slide. We've already had a lot of inspiration, but I think these three speakers really speak to the heart of what it means to address social determinants of health. Dr. Kamara Phyllis-Jones, who is considered a U.S. expert in social determinants of health, she says, when a flower doesn't bloom, you fix the environment in which it grows, not the flower. Sir Michael Marmot out of London, who's an international expert in social determinants of health, he says that inequities in power money and resources give rise to inequities in the conditions of daily life, which in turn lead to inequities in health. And obviously, Dr. Martin Luther King stated that of all the forms of inequality, injustice in health is the most inhuman because it often results in physical death. The reality is that if we don't address social determinants of health, it certainly can lead to the loss of life. Next slide. And so as we begin this discussion and we look at the definition, and we heard great definitions, this is from the World Health Organization. It says that social determinants of health are economic and social conditions that influence the health of people and communities. It's shaped by the amount of money, power, and resources that people have, all of which are influenced by policy choices. And so we know after this election season that policies have to align themselves with the goals of improving overall health. And it's certainly a challenge, but it's a collaborative effort that is certainly needed. And in the conversations mentioned this morning, it's certainly, you were able to see that it takes an interdisciplinary team approach to address these issues. Next slide. And when you look at some of the specific examples, we know access to quality health care is a part of social determinants of health. Discrimination is a huge part. Education, the graph to the right shows that we know that advanced education is associated with lower percentage of adults with poor and fair health. So the higher education, then your health tends to be better. But the lower education certainly affects health and the quality of it. Employment has something to do with this. Food insecurity, the quality of foods, access to foods. Dr. Nigam mentioned the food desert issue. I live in Dallas, Texas. We have individuals who live in zip codes who are a 2-hour bus ride from the nearest grocery store. That is significant. And I also know Houston's challenges as well, being a student there. Income, safe housing, and also social support has a lot to do in terms of the examples. Next slide. And as we drill down deeper into this issue, we look at, with economic stability, you have income, expenses, debt, medical bills, and support that are a part of this. Neighborhood and physical environment, housing, transportation, safety, parks, playgrounds, walkability, education, there are issues. Then we have the food issue. We mentioned food insecurity, food access to healthy options, and what that does. The social context and the social construct, which we're seeing more and more plays a role. And we're going to talk a little bit about what's considered societal risk factors. And those are the adverse social conditions that are associated with poor health and how that plays a role. And then the healthcare system. And if you look at the bottom, all of these together work towards health outcomes, which has to do with morbidity, the quality of life, mortality, death, life expectancy, which has been mentioned already and previously, healthcare expenditures, how much money is being spent, the status, and then functional limitations. Next slide. When we look at the effects of COVID-19, how do these social determinants of health play in on that? Well, we know the housing instability, the certain loss of wages, crowded, low-income housing has had an effect. We know that food insecurity has led to shortages due to stockpiling. We know that lower income shoppers are less likely to be able to purchase the food they need. Then we know the social isolation. We've been all isolated in these months, and that exacerbates loneliness and also this lack of motivation. And we're going to get into obesity and specifically how obesity plays to some of these issues as well. And then the access to internet and necessary technology for virtual interactions. We all saw in Arizona where the 2 children were at Taco Bell and they were on their, they were trying to get internet access to be able to do their homework, because we know that access to internet is not by everybody. In Dallas Independent School District, it was reported 40% of kids don't have access to the internet. And then prejudice and discrimination. We know that Asian Americans face an increased risk for mental health challenges. The business owners may face steep revenue losses, and those are things that are certainly played out in the COVID space. Next slide. And specifically, we know that this results in, as Martin Luther King mentioned, the loss of life. We know that COVID-19 has led to, in the African-American population, 3 times higher rate of infection with a 6 times higher rate of mortality. And that hypertension, diabetes, and obesity, all disease states which are connected to social disparities and social determinants of health, disproportionately affect the minority populations. And so as we look to solve these issues, we certainly are hoping that we see improved health outcomes associated with that as well. Next slide. Specifically, and then also hospitalization. Up until October this year, they took a look at the highest hospitalizations, and it was, again, in minority populations: American Indian, African American, Hispanic, all top 3 in terms of hospitalizations associated with COVID-19. So these social determinants of health play an extreme role in health response in these populations of individuals. Next slide. So structural racism, social risk, and COVID-19 are also play a role. And structural racism has to do with inequitable systems in healthcare systems. And you combine that with health and societal risk factors where you have some of these adverse social conditions, and they all are contributed to by 4 things: medical mistrust. We in our country, Jessica spoke so powerfully, and it made me think about the mistrust. About 3 weeks ago, my wife and I sat down with our 4 children, and we explained to them the Tuskegee experiment. I was watching a movie that was Miss Everett's Boys, and it was referencing the Tuskegee experiment, and to see their faces when we talked about a 40-year experiment that led to African-American males being intentionally given syphilis, and to see their response was unbelievable. So some of those seeds of mistrust are still there, and that's why some minority populations don't go get the care and be a part of studies that certainly are needed to improve health. Unconscious bias. We know that some of those issues, implicit and explicit bias, play a role in healthcare disparities. Stereotyping, and then prejudice as well. And we've seen that work in regards to some of the response to COVID-19 and the alarming death rates. Next slide. So what is the goal or the triple aim of social determinants of health? And this was in the Centers for Medicare and Medicaid Services in a publication. And they're like, what are the solutions? And they say this in 3 areas: healthier people, better care, smarter spending. Some of the things that we're going to be mentioning have been already talked about today, but we're going to address all 3 of these areas. And I think that some of these tips can help us in our efforts to improve these social determinants of health issues. So number 1, healthier people. Next slide. That has to do with enhanced health outcomes and partnering with patients. And now we're going to drill down into obesity a little bit. Next slide. From an obesity perspective, we know obesity is a disease. It's not managed as a chronic disease, but the World Health Organization, the FDA have stated that since the year 2000, we've had national organizations state that obesity is a disease and that weight loss is the primary focus of care. We know that BMI is the main metric, and that the etiology has to be addressed and understood more and more. And that is a part of the collaborative effort of the healthcare system and the community and employers such as yourselves coming together to really address this issue. Because what we know is the prevalence and cost of obesity are going up. 42% of the US adults have obesity. When you compare that to China, at only 6% obesity, Italy only has 10% obesity, and we're at 42%. There has been a 12% increase from the year 2000 up until 2018, and that has resulted in a $1.72 trillion annual cost to chronic diseases associated with obesity as of 2018. So that's sobering statistics. And then when you apply some of those social determinants of health to obesity specifically, we look at down below, we see that in the white population, you have 2 in 5 white individuals who are affected by obesity, but in the Black and Latino population, it's 1 in 2. And then what we also know is that lower education and lower income results in both 1.5 times more likely for those individuals to be obese. So it's a pretty significant issue. Next slide. And these are some of the contributors, and all of these fall within the context of social determinants of health. And what we know is that from an obesity perspective, there are contributors that are inside the person and outside the person. And these contributors are social, psychological, they're societal, they're environmental, they're economic. And all of these work to contribute to obesity as a whole and the problem that we have with this specific disease state. And solving these issues has to do with addressing some of these areas specifically. Next slide. So what are some of these factors that are driving the prevalence? We know that 51% of individuals from a psychological perspective state that lack of motivation towards initiating weight loss is a part of the problem in terms of people with obesity. We know that 21% of BMI variation can be accounted by genetic variation. So understanding those genetic differences and predispositions are important. And then what we also know is that there's less than 1 in 2 state employee programs that offer coverage for obesity related pharmacotherapies in states across the United States. And so that's extremely important. We're talking about less than 50%, that 50% of states having anti-obesity medication coverage, and that's significant, and that certainly has to increase to be able to address this issue. And that we also know that 32% increase in the incidence over 10 years for women in lowest neighborhood of socioeconomic status is a part of the problem as well. Next slide. And then we also know that food environments, we know that stores in high income neighborhoods are 3 to 2.2 times more likely to stock recommended diet items. There's more fruits, more vegetables. There's also the problem of correlating healthy eating to price, thinking that it's more expensive to eat healthier. We know that obesity prevalence is lower when you have access to green space, and we also know that that when you have a sibling that is obese, there's a lot higher likelihood for you to suffer with that as well. And that we know that being able to have that green space and building environments with access to walking environments is really important. And what the concern is now during the winter months, we're going to see less physical activity due to the cold. So certainly it's something that we need to be thinking about. Next slide. So better care. So this has to do with improved care delivery and the availability of information to guide decision making. Next slide. And what are some of the things that we're seeing there? And it's just really approaching helping our physicians. We know that from a healthcare physician adherence perspective, only 50% of physicians recommend improvements in physical activity. There's 33% that really highlight the guidelines in terms of eating a healthy diet. Less than 20% of physicians recommend counseling for people with obesity who suffer specifically with this disease. And then there's a lower percentage of individuals, the 31% that don't prescribe pharmacotherapy. Anti-obesity medications play a huge role in addressing the issue of obesity management. And so certainly that has to be looked at as well. And 11% do not propose surgery as an option as well. Next slide. And so what is the solution? The solution is to create an integrated approach to obesity care. And this is the relationship between clinical systems, individuals who are suffering with it, and their families and communities. And I'll show you some examples that Novo Nordisk has specifically done to address this issue, because what we want to see is these programs give individualized health outcome improvement. We see economics of population health improve, and health equity, something that was mentioned, Jessica mentioned it earlier, where there are no barriers to the access to everything needed for good health. We remove those barriers. And so that's why that's so very important. Next slide. So integrated approach, when you have everyone working together, you can see we know that it's important because there's a 60% greater risk of all-cause mortality in people with obesity based on their incidence. And we know that obesity is an underlying cause of several comorbidities. There's a higher risk of diabetes, cardiovascular disease, cancers, and dementia. And so that's why it's so very important. Next slide. And then we also know that the integrated approach is important from a cost. We know that there's 27% growth in medical costs due to obesity. 3% of our country's healthcare costs are attributed to obesity. And there's a $66 billion per year increase in medical costs for obesity-related disease treatment. Next slide. And we also know that due to these socioeconomic inequalities, that 40% of studies show that there's a widening gap that is getting worse. And if we don't address it, it will continue to get worse. Next slide. So what needs to happen? It's a relationship where the individual sits in the middle, and then on the outside, and with the individuals, the family members and caregivers, and on the community systems includes employers, payers, providers, policymakers, the community planners, physicians, surgeons, nurses on the other side, everyone working together to improve obesity management. And this is the way we're going to provide solutions to help patients get better, and to see employees get better, and to see our communities get better as a whole. Next slide. And what we know is that persons with obesity should actively engage in the care process. And we know from patients who are supported, they see their medical costs go down by 5.3%, 12.5% hospitalizations decrease, and then specifically in their BMI, we see a 0.12 reduction in their BMI, their Z-score, and then their children's daily calorie intake goes down as well. Next slide. We also see greater weight loss. We see that hospitals having the actual tools that they need to provide care to individuals with obesity, because bias plays a significant role. And this is all a part of the integrated model approach. Next slide. So, and how does this work? What we've seen is in recent integrated care models, the Cleveland Clinic, they have an integrated model, and they've seen 34% increase in diagnosis of persons with obesity. We see in Confluence Health, 7.9% increase in absolute weight loss. The Guthrie system has seen a 30% increase in prescriptions for anti-obesity medications, and Mercy Health System has seen a 19% increase in prescriptions with anti-obesity medications. Next slide. And we also see from an advocacy perspective, we see organizations such as the STOP, the Obesity Alliance, the Strategies to Overcome and Prevent Obesity Alliance. The individual, Mr. Deitz, just came out with an article, and he highlights the social determinants of health and health disparities in his conversation. So this is being seen and understood and addressed. So following some of these organizations, the Obesity Society, the Obesity Medicine Association, some of your state and local organizations, some of the things referenced earlier, and then weight loss management centers, all of these are looking at an integrated approach to obesity care as a part of what they're doing moving forward. Next slide. So smarter spending. Lastly, want to end on some of the things that Novo Nordisk specifically is doing to address some of these issues when you talk about social determinants of health, and some of the things. And what we know is that for smarter spending includes incentive, paying for value, improving from an incentive standpoint, engaging providers, and engaging the community as a whole. Next slide. And what Novo specifically has done is we've worked in the community to address social determinants of health. Next slide. And one of the first things that we've done has been in the city of Houston, our Cities Changing Diabetes initiative, and we work with the Hope Clinic there in Houston, Texas, and that is a clinic that is focused on helping inner city diabetes rates improve by improving their functioning, and they have a goal that by 2045, if they reduce obesity, and by 25%, we're going to prevent 149,000 cases of type 2 diabetes and save $1.5 billion in healthcare expenditure. And that's just in the city of Houston. The program has worked so well that it's been expanded to Philadelphia. And so those types of partnerships are extremely important. That's why it was so awesome to hear Dr. Nigam talk about going into the community, going to patient homes. And how apropos is that? That's the way healthcare used to be, where doctors made visits at homes and knew their patients. And then you're talking about a healthcare system. So this particular example worked also with the Hope Care Clinic and community chefs and cooks to transform the food culture, to teach individuals how to cook so that they can be healthier as well. Next slide. And then the Farmhouse to Your House was a partnership with Novo Nordisk in the state of Mississippi, ranked #1 in obesity, #2 in diabetes, and working with the diabetes prevention program to lower the amount of diabetes in the area, and then to work with farms to be able to provide fresh fruits and vegetables to individuals needed so that they would eat healthier. And from eating healthier, that helps to in turn help their diabetes, and then working with the community as well. So it's going to take active involvement of all of us in the community to help turn some of these situations around. In addition, Novo has worked with the Native American population in North Dakota, Discovery Health in New Jersey. Next slide. The Boys and Girls Club in Trenton, New Jersey, and Plan Ready, Set, Health, Get Healthy in Trenton, New Jersey. The farmers, Greenwood Avenue Farmers in New Jersey, the Garden State, if you will, and working with getting fruits and vegetables and working with organizations where individuals who needed WIC and SNAP help were able to get healthcare screenings and nutrition education. Next slide. And then also at the University of Pennsylvania, working in New Jersey as well, and the food pantry in New Jersey. All of these areas, getting actively involved, getting our hands dirty. As Jessica mentioned earlier, we have to care about the environment and get actively involved in these communities to be able to turn some of these situations around. Next slide. And these are some of the other examples. Next slide. And this is the final example. So next slide is, and I just leave you with a couple questions. Next slide, a couple questions. Next slide. How does social determinants of health affect your world, and what are you doing about it? I think that's a question all of us can answer, and all of our organizations can take a look at. Next slide. Which of the discussed social determinants of health most resonates within your purview of your organization? Which ones? Is it food insecurities? Is it discrimination? Is it income? How can your organization be a part of addressing that issue? Next slide. Which ones are you most focused on? Next slide. And how do you currently screen for, record, and address social determinants of health? And last slide. What products and services will help you implement and track social determinants of health improvement initiatives? So thank you so much for your time. Chris, thank you.
Wow. That was a great flyby, Courtney. I have a question for you though, and I think this was an error, but if Dr. Nigam would like to comment on this from what his perspective, if he's still there, I would appreciate his thoughts. So Rupesh, if you're still out there and want to turn your camera on, I'd ask you to respond to this based on what you're doing in the market. So Dr. Nigam.
Thanks, Chris. Courtney, very powerful presentation. Thank you for bringing all these important points out. Obesity is an epidemic. Obesity certainly is an epidemic, and as Courtney pointed out in the data, it's astounding to see those numbers going up from 2000s, 12% to now 42% of our patient population. And there are numerous studies which show us obesity rates correlating with increased rates of cancers, increased rates of all other diseases, diabetes and your joint problems for crying out loud. So there certainly is that correlation. Now, what can we do as providers to help our patients understand this? Again, we get back to healthcare literacy. how food choices, how day-to-day food choices affect their health outcomes is fairly important. We do have a lot of data to provide to the patients when they come in to see the physicians. We give them handouts. But honestly speaking, as now I'm going to mention to you as a healthcare consumer myself, when I go to the doctor's office, I get, a bunch of papers stapled together. How many of those do I actually read? Most of the time they're lying in my trunk. So if you're not, sitting down and having those discussions with the patient one-on-one and making them actually understand, it just goes so far. I'll tell you tidbits of, I still see patients day to day. You hand over a piece of paper with a patient, they'll sit in front of you, they'll nod their head as if they understand everything. But 80% of the patients, when they go back home, if you call them up a day later and ask them what the doctor actually tell you, they don't remember things. And that's where going to the patient's home, sitting with them on their dining table and discussing this again is very powerful. Coming back to the whole, the big picture, standing back and looking at, this whole panel discussion around the social determinants of health, I think, we need to certainly change our outlook towards how we address this problem. And I take us back to Elena's slide where she showed the disparity of how much resources we direct towards the social determinants of health versus towards actually taking healthcare in our country. And this needs to be discussed at a much higher level and then percolated down to the consumer, to the patient. With market leaders and thinkers that are accumulated here on this panel, I'm hoping that we can start this discussion and carry this forward. So again, I completely agree with all the presentations that have been made today.
One question for each of you, and then we're going to move on. Dr. Nigam, is Kelsey, are they practicing the integrated model of treatment as Courtney had described?
We are. So we are your doctors. Kelsey's slogan now is changing the way healthcare is, and we are providers for patients right from pediatricians or even OB delivery to the end of life. And the advantage of having capitated patients is that we do see generations of patients. So if we talk about good health care to the patient's child and then mother and then the entire family, we do have that. Now, integration as far as providing services, providing drugs to address obesity, providing weight loss surgery, all of those options are provided to our patients. So that integration certainly is there with us, as providers. If there are any particular areas that you would like me to point out, Chris, I'm happy to do so.
No. I just because I've heard a lot about the integrated care model over the last year. Courtney, this is for you. Going back to the racial equity and social determinants of health, are you aware of employers that have, you provided some really good information about how obesity is impacted by this. Are you aware of employers who have taken this information and really kind of got into the data to support this in their own populations? I mean, you have to dig into the data to understand the obesity and the social determinants of health and making it easier for those individuals. For instance, no copays on any of the medications that are required for pharmacotherapy treatment, because these things are not expensive. And are you aware of employers that are moving in this way with respect to benefits design?
I think that that's something certainly that we're growing in our awareness. One employer specifically, Humana, has the Bold Gold Initiative, and their Bold Gold Initiative is focused on addressing some of the issues in terms of social determinants of health from a societal perspective. But I think we're growing in awareness, and you and I were a part of a couple years ago. I think we're trying to address some of the issues with obesity in terms of from an ICD-9 code perspective, being able to cover obesity. It is a moving target. We're moving towards, number one, the acknowledgement of obesity as a disease, number one, and then number two, being able to cover. So some of the struggles from a benefit standpoint is if it's not, is we're moving towards obesity not being considered a lifestyle issue as smoking was in the 80s. Obesity is moving towards really being recognized now as a disease that leads to further disease. And as we're now really seeing employers embrace that, that has been a part of our conversation. That has been a huge component of what we're doing. We're seeing it. One of the things, the University of Texas system, when Saxenda, which is liraglutide 3 milligrams, came out, they were one of the first employers that stood up to over 250,000 employees within the University of Texas system and said, hey, we want Saxenda available for our population to be able to address this issue of obesity. And they fought to get a rider to make sure that it was available to their employee population. So that's one example. And then also the Humana Bold Gold Initiative, I think, working in the community to address social determinants of health. So it's certainly something that we are all working very heavily on trying to turn around.
Very good. I again, one of these topics we can talk to for a long time, but this is great. Again, it's the beginning. It's not the end. We have a great relationship with Novo Nordisk and good partnership on making educational awareness. And again, the literacy is so huge. So what I'd like to do is to ask Dr. Nigam and Dr. Walker to turn off their cameras and their mics, and I'd like to go to the next slide and ask Denise Crandon with the Houston Independent School District to turn on her camera.
Hi, Chris. How are you?
Hi, Denise. I'm well. How about you?
We're great. Unfortunately, the internet is completely down now because of the storm, but I am here using my audio.
Okay, very good. Well, so Denise is also on our board. Denise Crandon is the Senior Medical Manager for Benefits at HISD, and we wanted to provide an opportunity, and again, chat if you want, but the question that came up when we were thinking about this particular annual well-being forum, with all the changes that have occurred working remotely, how is this going to impact benefits design or well-being programs in 2021? What are the changes? How are you needing to shift? And what are some of the challenges and opportunities that you may have experienced? So, not to put you on the spot, Denise, but let's start with HISD. How has it impacted HISD, and what are you doing, or what do you see as challenges and opportunities, Denise?
Great question, Chris. Well, first of all, as you know, because of the pandemic, we've had to change the way that we operate not only our business, but how we deliver communications to our employees. One of the things that we've done recently was related to our flu shots. Typically, we go out to all 280 campuses throughout the city of Houston to deliver flu shots on site. So what we did was we set up tents on Saturdays from the hours of 10 to 2, where people could drive through and get their flu shots. We did that this year, and that worked out very well because, as you know, a lot of people did not want to interact with staff or with members of the technicians for the flu shot vendors. So that worked out very well. And as we move forward with COVID-19 vaccinations, that's something we also need to think about, because as Dr. Walker just said, there is a lot of mistrust with the medical community in our underutilized populations. So we need to think about, number one, how are we going to communicate to everyone that there is a vaccine available, and that, especially in communities of color, we need to get the word out in terms of, okay, vaccines are here and we need to get those done. So we are currently working on developing a plan for that as well. And we don't know, maybe we may have to end up partnering with other medical facilities to provide them either at a specific site or maybe do drive-throughs. Because again, there was a lot of mistrust, a lot of hesitation with the flu shots. So we're going to expect that as well with the COVID-19 vaccinations. Also, we've done little snippets of videos that were related to topics like Livongo Diabetes Program, which we have through our pharmacy benefit manager. We have done videos related to free 90-day generic medications for those that have diabetes, hypertension, and high cholesterol. We have also offered a number of webinars related to our employee assistance program on stress, on relationships. The statistics are showing that everyone is stressed out. Everyone, they're pretty much at their breaking point. There are a lot of relationship issues, high divorce rate right now because of COVID-19. Cool. So we've done a number of different webinars related to that. Also, we are planning to roll out Navigate Well, which is a wonderful app that people just put on their phones or go to the website, and you can go on that app and do actual challenges. They're personal challenges as well as group challenges. Especially now, people are feeling so disconnected from one another. You're able to do group challenges with one another on there. If they go through and do a number of different activities, including challenges, activities like going and having their preventive exams done, they receive points throughout the year. And at the end of the year, their name will be entered into a drawing to receive an incentive. So those are some of the things that we are planning to roll out for 2021. We'll continue to use our social media platforms as well as mailing out postcards. I know it sounds really archaic, but no. we have found that the members that are in the underprivileged or underutilized communities, they have a tendency to want to see things in writing. They want a piece of paper rather than using virtual sessions. So we will continue to work with our vendors to send out postcards for things like EAP reminders in terms of what the EAP program provides. A lot of people just think it's solely counseling, but it's much more than that. It's also work-life balance resources that are available to all members, household members. So we'll continue on that route. We're also looking at doing virtual wellness fairs. Most of our vendors have said that they are able to help us with that and provide support for that. So we'll continue that effort. And then something that Jessica mentioned earlier in terms of the lack of medical resources in some of the underprivileged communities. In Houston, we've noticed a significant gap in the areas that are kind of north of I-10, but east of I-45. We've noticed that many of our members are not able to get to providers easily. They have to, as Dr. Walker was saying, hop on the bus, take a number of different buses to get to medical care. So we are currently working with some of our medical vendors to determine, number one, can we maybe possibly open up additional near-site clinics or additional on-site clinics, because we currently have 2, but we are looking on in terms of expanding that as well. And then we're also talking with our TPA about the possibility of using some of their health hubs for additional treatment for members that are in some of the underutilized communities. So those are some of the things that we're focusing on right now.
Denise, a question for you.
Sure.
have you worked with your health plan or looking at the data to see the impact through COVID of adherence on medications or vaccinations? Are you seeing, are you actually seeing this? It's just not happening? Is that something you're able to monitor?
Yes, we do monitor our pharmacy data as well as our health plan data. And on the pharmacy side, I can tell you that we've definitely noticed an increase in our 90-day supply. We noticed that at the beginning of the pandemic, and that's just because it's easier for people to get that rather than going back and forth to the pharmacies. So there is increased utilization there. There's also increased utilization for mental health related drugs. And again, that speaks to the data that mental health issues are on the rise. So we're seeing that as well. But we have seen a little bit, not where we want it in terms of utilization for preventive services, because during the pandemic, people did not want to go in and have those services done. But slowly but surely, it's starting to pick up now.
Interestingly, not HISD or maybe HISD, but we HBCH has a partnership with the Hope Clinic, and I regularly speak with Dr. Andrea Karakostas, and I was surprised to hear that employees who have health insurance, good health insurance with the school districts, are showing up for the FQHCs because of an access timeliness of being able to see somebody. I just found that interesting, and perhaps again, these teachers are not, kid's mom is a teacher. They're not the highest paid profession. And so this is very difficult. And so they're showing up at FQHCs, even though they have health insurance for their care. Have you heard about that or aware of it?
Yes, we are aware of it. And again, we are working with some of our vendors to develop different modes or modalities to receive care. We do have, again, our 2 on-site clinics where they can go and receive free care. We also have a contract with our on-site clinic administrator to provide near-site services at some of their centers throughout the city, at the 14 centers that they have throughout the city. So we're continuing to work with them to develop, again, different plans or different ideas to address that population. And also there is a bit of education that we are continuing to push, because many people don't realize, hey, do you know you can go after hours to a next level clinic and receive care for $20, or if they're in the select plan for people that are under a certain salary threshold, they can receive care, at no cost. So a lot of people don't really know that. So we're going to, again, continue to push it, social media, push it on emails, etc.
One question that I've wondered, we're hearing about the COVID vaccinations, and the first priority will be healthcare workers. The next will be folks in nursing homes like my mom, and then it's going to go to the population. But in your environment, I wonder if employers are thinking strategically, okay, who gets it first? It seems like you'd want to take care of those who are underutilized, or perhaps in areas of the city that are more at risk. Has that come up in any conversation, or I wonder?
We had a conversation yesterday in terms of working with our healthcare partners to get the vaccine out. We are starting discussions with them. Those are primarily driven by what each individual state will do, and then based upon what the findings there, we will then push it out. But we've already, started talking to Kelsey, starting talking to Aetna, Express Scripts. We are trying to get all the information together, because we know that, number one, we've got to address some of our first responders, because we have police officers, we have nurses at schools. Those people need to go first. So we're developing a plan.
I get it. It's complex. Our current board chair, Sue Prohaska, said we really need to do something early in January, kind of have a webinar to focus on all of these issues. I didn't even think about, okay, the police officers, there's a whole lot of stuff going on there. So we'll have to make sure we provide some awareness. I'm looking at the questions, and we don't have them, but I think it's great that I think you did a great job of providing options. I hadn't even thought about some of these things. The mistrust thing, I've heard that before in underserved communities, and
and Chris, I'm going to be honest with you, not just in the underserved communities, because as a minority myself, I can tell you that in speaking to many educated minorities, there is still a level of mistrust in terms of the vaccine. So I know that at the end of the day, I've got to get it done because my life will depend upon it. But spreading that message to others and getting them to understand and getting them to believe in it, that is a challenge that we all face. And it's something we have to overcome because we've got to get back to the new normal, so to speak. And we know it's going to take a while, but
I heard on one of the national talk shows. I was just going to say, I heard on one of the national talk shows that communication that you talked about, that how important it is to temporarily link that messaging, like you talked about with the cards and everything, with the availability. Someone will say, well, how come you're not doing it all now? And I guess the science says you have to temporarily connect the communications with the availability. It doesn't do any good to do it right now. So I thought that was interesting and a point that employers may want to consider. So we are at our time here, and go to the last slide, please, Sam. The next last, now one more, there you go. So I want to thank you all, and we couldn't put on these programs without our team. And so Sam Medina is our operations manager. Corey Owens is our project coordinator and senior admin. Alexis Tahara, who's now going to nursing school, is our social media specialist, and Carrie Conway does all of our public relations. So I just want to thank them all for another great year. And I want to thank all of our members. By the way, invoices are going to be going out for 2021 next week. But thank you again for your attention through this, and we look forward. We're going to start off virtual in 2021. Based on what we're thinking, we're not giving up the ghost on having an in-live conference late next year. Based on what we're hearing, but we have to go with the flow. So again, thank you, and everybody have a wonderful holiday season, and we'll be in touch. Bye-bye.
Thank you, Chris. Bye-bye.
Thank you.